If you distill the fundamental idea of healthcare down to its purest, most unadulterated form, the essence of it just seems so simple. When someone is sick, they should get the care that they need. And this should be true for all of us humans living right now, forever on the cutting edge of the future, riding around on this blue and green orb through the universe and living our shared history as a species. But there's a heartbreaking reality to healthcare, and cancer in particular. The messy and upsetting truth is that the number of people who can get the best care, if we can even agree on what that means, which we can't, is fractional. Untold numbers of people can't even get decent care, and millions of people get absolutely no care at all. So why is that? There are glaring, enormous problems plaguing medicine and medical systems around the world. How do we unwind them? How do we even understand them? And for all the individuals in the world with cancer who are struggling, how can we bring them within reach? It's a lofty goal, but it's the one we're going to tackle right here. I'm Evan Young, and this is Within Reach from Avalere Health. University of Kansas sophomore Zach Schrader sat over his genetics exam. The clock was ticking, and Zach was crying. For the past month, he'd been losing weight. He was fatigued. He felt awful. It collapsed in on him in this moment, and he broke down. Not long after, in a cruel twist of fate and timing, he was handed a diagnosis for his 21st birthday: stage 3 melanoma. There was no cake. There was no celebration. There was, however, the beginning of a long road ahead of him. And I don't mean just a figurative road, I mean a literal road. Because for the following weeks and the host of procedures and treatments he would need, all the imaging, the surgery to remove 50 lymph nodes, radiation, and 12 rounds of immunotherapy, he would have to travel. And I mean far. Zach hails from a small town of just 8,500 people in southeastern Kansas, where far might have a different definition for people there than it does for the people who spent their lives in more urban areas. If you live in Honolulu, far might be a 1-hour drive up to the North Shore. Or maybe you're a Londoner, and far is a couple of hours down to Southampton. But these are not Kansas far, or American Midwest far. In this case, with Zach, he had to travel 500 miles away from home for his care. 500 miles in one direction. Now, it may be tough to wrap your head around how vast the US truly is. So just to help with perspective, Zach had to drive the equivalent of a trip from London to Frankfurt, Germany, or from Washington, D.C. to Portland, Maine, just to get the care he needed. This is a staggering thought. But overcoming the financial and emotional tolls of distance are not the only ones that make rural cancer care problematic. People who live in rural areas don't have the same access to clinical trials. They don't have the same access to resources, including a vehicle to even make that drive. Socioeconomics are a barrier on their road to treatment. Food insecurity is a barrier. And these barriers in rural cancer care can lead to higher mortality rates, something that was likely weighing very deeply on the mind of Zach, a young 21-year-old with a dangerous cancer. Today, my guests are Dr. Wade Swenson, a hematologist-oncologist and the founder and president of the Rural Cancer Institute, and Ryan Taggart, business director at Avalere Health. We discuss these barriers in rural cancer care and some ways we can clear them away. That's all coming up next on Within Reach. Wade, Ryan, thank you so much for joining me today. I'm really happy to have you both. I'm looking forward to this conversation. I think it's going to be really uniquely interesting for all of us to be thinking about and talking about rural health and particularly oncology care for rural populations. So welcome.
Thank you. Nice to be here.
Great to be here.
First, I do think it would be helpful to just level set everybody on the very idea of what the rural setting is and rural health in particular. So just by way of background, I lived most of my life in some of the world's most densely populated areas. I grew up in South Jersey, which we all know, Jersey is like the most populous state in the Union. I lived in Philadelphia. I've lived in New York. I even lived in Bangkok for a bunch of years. So urban is sort of my background. Now, I've moved out to the suburbs. I actually live in horse country down here, but there's a CVS 2 minutes away. I suspect that that's the experience of a lot of people. And what I really would like to do, Wade, for you to talk first is to just, if you could capture for us the idea when we talk about a rural setting and what rural care really starts to look like, how can you just help mentally ground us in what that truly means, assuming it's not rolling fields of wheat and cows? That's like the idyllic version of what rural is. And I believe that that's not true. So if you could just get us grounded in the right frame of mind, that would be awesome.
Sure. Yeah, great question. I think it's a good place to start. So, rural can be a lot of different things. Rural is a very heterogeneous topic. So, when I think of rural, I like to ask people what they think the most rural state is, because there's not really a clear answer. When you think about rural, Alaska would probably be the most rural state because it's the least densely populated. But Texas is also the most rural state because it has the most rural residents of over 4 million. North Carolina is right behind them. But another answer to that would be correct is Vermont. Vermont has 65% of the residents are rural, and that's the biggest percentage. And so there's a lot of ways you can define this. And as a result, the rural health issues and the rural health obstacles to care, they're all very different depending on what you're talking about for rural. Where I am in Minnesota, we're technically considered a frontier county. So that's a different level of rural where distance is one of the biggest barriers to care. And so when we're talking about rural, it's really important to understand that it's not just a uniform problem. In Appalachia, we have a lot different issues than we do in rural Minnesota. In rural Montana, it's a lot different. So, where I practice in central Minnesota, in Staples, Minnesota, it's a town of 3,000 people, and we're trying to deliver cancer care in that town. Where I was before, also rural in Minnesota, is about 20,000 people, totally different problems and totally different obstacles to care. So, it depends on what you're talking about for rural where you are, but it's an important distinction because it really helps define how to deliver that care and what kind of needs the community has.
So was the answer Alaska? I'm not sure if I would have guessed Alaska. I mean, I think that's a great way to think about it. I mean, honestly, I might have said Iowa, something like that, but that's really interesting. I also didn't know that there even was such a thing as a frontier county.
I was just thinking of as you're mentioning sort of the heterogeneity of this, are there certain criteria that could, get us into the framework of what makes up that heterogeneity, maybe 3, 4 different segments, frameworks?
Yeah, there's a lot of different definitions of rural. The government uses over a dozen rural definitions. And so depending on the department, depending on the grant that you're applying for, depending on the organization, whether it's economic development or healthcare. So, one definition of rural is simply non-metropolitan. And so a county under 50,000 people is considered rural in some definitions. But then there's also commuting codes and whether people are driving to work. So there's a lot of different ways that rural is defined. I find it interesting that when I go to a town about 25 minutes from where I practice, I think that most people there would not consider that town rural. I definitely consider that town rural. It's just really a perspective. And I think there's a cultural competency that comes along with delivering care in rural. When I send people to Mayo Clinic, for example, and about a third of my patients do go to Mayo Clinic at some time during their care, they really do understand the rural patients. They try to put all of the appointments together and batch them together. So understanding that patients are driving a long ways to come see them. There's a lot of different things like that that are important when you're caring for a rural patient. The definitions are important, but I think maybe we get caught up in the details. One person I saw described rural as how far you are from the nearest Walmart or how far you are from the nearest McDonald's. And so that's kind of an interesting way to approach it.
So forget how the government wants to define it if there's way too many definitions for your purposes. What are one or two of the most important definitions relative to oncology care? Is it access? Is it treater or patient knowledge and education? Is it resources that are available in that immediate area? If you needed to zero in on what makes rural health care so distinct, which of the challenges are the most important to you?
Distance is the obvious answer, I think, right away. So, how far are you driving for your oncology care? How far are you driving to see your primary care physician? In Minnesota, if you're diagnosed with a cancer diagnosis and you're a rural resident, you're driving on average, and this is according to the Minnesota Hospital Association, 75 miles one way for your cancer care. Most cancer care is not just a one-time trip for your care. It's daily or weekly, and that really adds up. And the problem with this is that it affects not only the patient, but the daughter who takes time off to drive her, the caregivers that need to watch the kids because they're bringing their spouse in to get care, or the time off work. So it's affecting families, it's affecting caregivers, and so that distance really does add up. So I'd say that's my answer would be the distance. And so there's a lot of other factors. Where I work, rural tends to be sicker than their urban counterparts, poorer, and have less healthy habits. And so when you look at my patient population, a significant number does not have access to a car. Significant number, approximately 25%, is food insecure. And so there's a lot of other things that go along with rural, but distance is sort of that underlying problem.
We talk a lot about the burden of the caregiver in cancer care. And I think what you're mentioning is it's actually even greater from the rural perspective, just given the downstream, effects of for the caregiver, for the family itself, just given the distance that they would have to travel for their care.
Yep, absolutely. The caregiver, the workforce is one issue, but this affects so many people, affects the community. It's all encompassing. It's not just the provider.
Yeah. I'd love if you kind of took us back a little bit. Like for you, you could practice anywhere. What was, I guess, that first realization that kind of clicked for you that just said, rural cancer care, this is for me. This is what I want to be doing. This is what I'm here for.
It was a mentor bringing me into a rural practice, really realizing the opportunity to help people. And then the last 4 to 5 years working in a more rural place in the central part of the state where it was really an opportunity to make a difference, and finding a health system that really focused on the patient's needs in the community. The thing that really caught my attention there was the food insecurity work, the farmers market, the backpack for kids, the food pharmacy, the meals at discharge. As I mentioned, about a quarter of my patients are food insecure. It's a big problem. And so just seeing what they did in that space, it really prompted me to approach them and see, this might be a really nice place to work on a cancer program, just seeing their level of commitment.
So I'm glad you're talking about food insecurity specifically again. When you think about tackling some of the issues that you need to tackle to really increase the quality of care where you are, how much of it is attacking some of the more systemic or underlying issues of food insecurity or, like you said, healthy habits, versus how much of it is actually trying to solve the issues by approaching it in different ways?
Well, I think at the ground level here, we meet people where they are. We work on addressing issues that we can in the community, but that really does prompt a lot of the other work that I do with the Rural Cancer Institute, lobbying at the state, working with ASCO, American Society of Clinical Oncology, at the national level, and doing some advocacy work there. I'm actually working on a executive master's in policy leadership at Georgetown for the same reason. I really feel like a lot of what impacts what we do on the daily basis in practice is at the federal level, but there's a lot that can be impacted at the state level too. So I feel like, we want to do what we can with what we have and the policy tools and things we have currently, but it really prompts me to try to change those both through state level and federal advocacy.
We've been talking about the rural oncology patient, the caregiver, the settings, but I'm curious, like from your perspective, from your colleagues' perspective. I think for those of us who've been working in oncology, working with oncologists, mainly in academic settings, I'd love for you to kind of just take us through, when we talk about rural oncology, what's an actual day look like? Like take us through any Tuesday, say, like what does that look like?
So I work 3 to 4 days a week. Tuesdays, I'm usually in clinic, and so I will have probably 12 to 14 patients on my schedule. Start in the morning. Usually, I spend a lot of time with my nurse, my primary nurse, the patient navigator, the financial navigator. There's so many people who, I'll go into the clinic visit with a number of these people to address some of the needs. I mean, there's a lot that goes into a cancer diagnosis. The follow-ups are really nice. The follow-ups usually are quick and good news, but when we're dealing with somebody who has a new diagnosis, it's a very intensive visit with a lot of follow-up and things that we need to address. So typically the morning is 4 to 6 patients. Noon can be anything from we do chart rounds. We have 3 medical oncologists, 2 nurse practitioners, a radiation oncologist, and a palliative care oncologist. And so we all get together at noon once a week, usually Tuesdays, and go through cases. So any new treatment change, a patient progressed on their cancer and it needs a new treatment, any new consults. And so we try to review those as a group. Other days we have cancer conference. Other days we have provider meetings. So there's usually a noon meeting. And then in the afternoon, it tends to be more follow-up patients and consults. But there's a lot of, I usually fit in a meeting from something unrelated somewhere in there too. So it's a lot of scheduling. So it's very much clinic-based, typical clinic. It's a team approach, absolutely. So there's a lot of people involved in my clinic day. And then I think the team part is so important. So yeah, it's a fairly normal clinic day.
So, Wade, if you could then help an oncologist that works in Manhattan try to understand the difference between their day and what your day looks like, whether that's from a practice management perspective or an actual hands-on clinical care and treatment perspective, like what are some of the main differences?
Probably a big difference is in almost every bigger practice, you're going to be specializing in a specific cancer type. And so all of my colleagues and friends at Mayo Clinic have a very specific tumor type that they see, and I see everything that comes in the door. A lot of community oncologists work in the same manner, that they see everything. And so you do rely a lot on subspecialists. So as I mentioned, about a third of my patients go to Mayo Clinic at some point during their cancer journey. And so a lot of times that's right away for that initial diagnosis or a second opinion or a major treatment change or a procedure that just we can't do locally. One of the important things when we're practicing in rural is that we understand our limits, and we need to make sure that we're doing things that are appropriate. Quality measures are super important, and so we tend to follow, the NCCN guidelines to a T. So the primary difference, I would say, is just the breadth of practice, whereas we see everything. But also, I suspect, they're seeing patients who are traveling too, and they may be traveling an hour or 2 hours, just like we're seeing too. But the difference likely is when that patient goes to the local emergency room, it's a critical access hospital where I am, whether it's my hospital or a hospital an hour or 2 hours away. The resources are going to be much different at that critical access hospital than they are in outside of Manhattan. So there's the supporting services that are not in my clinic are going to be vastly different. And so, and unfortunately, a lot of the emergencies, a lot of the problems happen at night and when a clinic is not operational. So I'd say those are the two main differences.
I would think that there might be another difference just in terms of the patient, the family, the community. You know these patients, right? You know their families. You know this community. That has to be much different. And how does that impact then your practice and the way that you treat these patients?
Yeah, it definitely does. I mean, we see a lot of patients who I took care of their spouse, I took care of their uncle or their grandparents or their neighbor, and so that happens a lot. And so the other thing is, I mean, and this happens across rural too, is I mean, it's great, and it's also maybe a drawback. We go to the local store and everybody knows you. It is the connectedness, sort of the community pride and the community support is really striking. One of the things that developing the cancer program at Lakewood Health System, that it really allowed for an opportunity to build the foundation, just because there's so much goodwill and people want to help. And it's a easy place to focus their efforts. And so just seeing the community rally and support this program and support the patients is really inspiring.
I don't want this to sound like a silly question, but is HIPAA like an issue if you're so deeply integrated into a community like that? Like, is that something that people just don't think about the same way that the rest of us may think about it?
There's always the awkward conversation when somebody wants to talk about somebody and we can't. So no, it applies. We have to follow that. So, I mean, I wouldn't say it's a regular concern, but yeah, it's everybody knows everybody.
Rural settings oftentimes from a technologic perspective, you have to innovate, really out of necessity. So telehealth, obviously, I think being one, comes kind of top of mind. I guess now with AI and the advent of that, and just the greater acceptance of AI into medical practices, how does that impact you? And does it help? Are you kind of an early adopter of some of these technologies?
We spend a fair amount of time using telehealth. It really varied. So with the pandemic, everybody was using telehealth. By that, I mean all of our patients. They're different ages, different clinical scenarios. It's changed a lot now. It seems to me that younger patients use it a lot more than older patients. And it tends to be the patients that, in my practice, that use it the most are the ones who are just doing a regular follow-up after a cancer diagnosis. They want to go through the scan and the lab results, but they have to work. And so the working younger people, are, in my opinion, are the ones that tend to use the telehealth the most. Initially, when I started this practice, we were really cutting down on drive times for patients, which is a great metric to follow and show that we're making a difference. And then as the practice grew, patients are driving from farther and farther away. So those metrics look terrible because patients are driving 2 to 3 hours to see us. But the telehealth piece is really important for what we do. And the telehealth flexibilities that are scheduled to expire in December 31st of 27, those need to be made permanent. One of the things that we're really focused on trying to access and improve is clinical trial access for cancer patients in rural places. There was a paper published this month by Tafaya Haddad at Mayo Clinic, and she was showing work on a decentralized clinical trial model, which relies heavily on telehealth. And what they found was in a year of this program, the number of rural patients went from about 15%, I can't remember the exact number, to 30%. So 30% of their patients are rural. This shows that this works in rural. So they're using remote phlebotomists, they're using telehealth, they're using remote informed consent. And so, yeah, telehealth is an important tool that we can't let slip away. And it's something in our daily practice.
There's something you mentioned is expiring. What is that?
Yeah, during the pandemic, they extended some flexibilities for telehealth. So we could use telehealth. It didn't have to be just a rural patient, so urban and rural could all use it. It used to be very restrictive. I had never used telehealth before the pandemic. And another piece that's really important too is I didn't mention broadband, but the broadband in my area, we have 87 counties in the state of Minnesota, and Todd County has the third worst. So we have, all these obstacles, to overcome, but broadband is one. So the audio only, the telephone call, it sounds, simple, but we really need to continue coverage for the audio only clinic visit, because the patients who truly need this, the patients who truly don't have access, they have a phone, but they don't have the video capability. They don't have the access to the car. It's just the audio only is really important. And so that's more common for me to do an audio only visit than it is a telehealth video visit.
Yeah, that basic technology gap is something I think is fascinating, and it clearly sounds like it's related. So I'm going to have a little fun for just a minute, and Ryan, I'm going to put you on the spot. But when do you believe that AOL disconnected their dial-up service permanently? How long ago would you say that happened?
I'll say 2 years ago.
Good guess. The answer is less than a year ago, September 2025. And they disconnected about 160 something to about 170,000 subscribers that were still left, the vast majority of whom were rural subscribers. But it just does show you there's a huge difference in just your kind of fundamental basic technology and access to it that, we enjoy in our urban areas.
You mentioned clinical trials. If there were one thing you would suggest that we could do to change how clinical trials are designed, what would it be?
The decentralized clinical trials. So in my previous practice, we had 3 different groups that we worked with on clinical trials. Well, 4 actually. One was Mayo Clinic, and they had their own research group. That was fantastic. That got absorbed into a bigger international group. And since then, we worked with 3 regional partners, and it was not uncommon for us to screen, well, at least on a number of occasions, we screened 200 consecutive new cancer patients, which is a lot for us because we might get, 1,000, 1,500 new patients a year with a solid tumor cancer diagnosis. So 200 in a row, nobody's eligible. And it just seems the problem is these trials become more and more specific. They're subsets of subsets with a specific mutation. And so it's harder and harder to get these open. And then you have a clinical trial open at your site, and then nobody's eligible. And so we also ran into really silly logistical problems. One problem that really stuck with me was we had a patient who was enrolled in a clinical trial. There's a storm going through the area. We needed dry ice to send the sample in. We had so many hours. There was no dry ice in town. And so it was just that person got kicked off the clinical trial. It's just the most ridiculous thing. So to be able to decentralize that, to not put that local investment of the clinical trial nurse in the small rural setting, use them at the large institution, at the academic center, and then work with technology to draw the blood locally, to do the imaging locally, to do the informed consent by telehealth. It would just be a game changer.
Coming out of ASCO, right? So here we are just a couple of weeks out. I think we've certainly seen a lot of the headlines and the promise and the hope and just the improvements that we've made in general, just in cancer care over the last, say, 10, 15 years. I mean, it's been massive. I'm hoping you'll say yes, but you're seeing a lot of that innovation benefit your patients, right?
Absolutely. Yep. When we talk about the rural cancer gap, I like to show a graph which shows the last 20 to 25 years of cancer mortality rates in the US. And overall, we see a 25% decrease in cancer mortality across the whole country. But there's a gap that 20 to 25 years ago was fairly narrow, and that gap is still widening. And there's probably a lot of reasons for that. The biggest reason is thought to be lung cancer. So there's a study in cancer epidemiology last year that showed that of that cancer mortality difference between rural and urban, 44% of that is because of lung cancer. The problem with this is that lung cancer is becoming more and more complicated. It's really important now to do the genomics, the biomarker testing, because there is a big study that came out in pancreatic cancer at ASCO, a standing ovation in a room of 10,000 people, showing a huge mortality improvement, overall survival difference for an oral drug with a specific mutation in pancreatic cancer. The last time I saw a standing ovation at ASCO was Hercept in 2005.
Yeah.
So that was amazing. And then the problem with this is that we're seeing so many of these very specific mutations with drugs that work and make a huge difference in patients' lives, but we need to do the testing. I do some work with A Breath of Hope, which is a organization in Minnesota that focuses on biomarker testing in lung cancer. Specifically, we're having a conference in rural, and just because there's clear evidence that in rural, patients are not getting the lung cancer testing that's needed. And so I think there's different studies, but between 40 and 60% of patients in the US are not getting the appropriate treatment for their lung cancer. And that implies that we're not getting the right testing. And so we can get access to that. There's really important technologies that I think democratize cancer care and allow cancer care everywhere. And that is companies like Foundation One, like the Signatera testing, Tempus, that allow you to do this testing in the communities, and they give you all the same information as if you were in an academic center. So, another technology like that is the NCCN guidelines, and another is open evidence. I mean, there's a lot of technology that allows all of this to be done in small, rural, low-resourced settings, but it is making its way here.
Open evidence, you mentioned. Is that something you've adopted into your practice and you're using? Are you seeing that with your colleagues too?
Yes, yeah, I use it all the time. It's a game changer. It makes mistakes. I've got a few things that, you want to double check, just like every large language model and AI tool, but it is remarkable. It really does a good job of synthesizing information. Some of these big genomic reports, I've seen patients take those genomic reports, the PDF, the 30-page PDF, put it into ChatGPT or Claude, and then this is, they come in with all these very informed questions. And so I'm seeing patients doing this too. So it's fun to see. We live in exciting times.
There used to be where you'd hear from physicians that, oh, this Dr. Google thing, it became an annoyance almost.
Yeah.
But I started to hear it kind of trending in a different direction now, where the patients who are doing exactly what you're saying, they're feeding their information into Claude or ChatGPT and coming back with a real actual discussion guide where you could have a real legit conversation with that person. That's kind of what you're seeing?
Yeah, it's happening quite a bit actually. Yeah.
How do you feel about that?
I think it's great. I love the technology. I love that people are empowered. I think the more information we can give to patients and put information in their hands, the better. There's an exception to that, and that is when these CT scans and when these reports come to patients through the MyChart, and they get notified about a CT scan or a PET scan, and it's all jargon. And
Mm.
so it just creates so much anxiety. They see it before I see it. And most patients now in my practice will like, I looked at it, but I thought I'm just going to wait to see you and we'll go through this because it can create so much anxiety. I do generally like the trend of giving patients information, but we should give them information that's more patient friendly because it's anxiety provoking and sometimes causes way more problems than it's worth.
An even more interesting question for me is we're seeing a broad uptick for AI everywhere across the board, right? But is there something about AI and how the tool can be used by your patients or yourself in your practice that gives it the ability to uniquely address some of the challenges that you face in rural care?
I don't know if it's unique, but I use DAX, which is the ambient recorder. It basically helps synthesize notes, and that's a huge time saver. It's not perfect, but it really does make a difference. And so when it comes to workforce access, burnout, all these things that are huge, the workforce issues in rural, that is a game changer that makes a big difference. OpenAI is wonderful, as we mentioned. We're using AI somewhat even in the revenue cycle at our hospital. So, I mean, it's being incorporated in a lot of different ways. Using it, in clinical trial matching will be huge, especially when we have decentralized trials become more common. But it's really fascinating to me how quickly this technology is being adopted.
Yeah, I saw a stat where it was, I think, somewhere in the neighborhood of 700,000 HCPs are on open evidence in a given week, I believe. Yeah, and
Yeah,
it's increasing.
it's amazing.
So yeah, you're exactly right. Take has been remarkable.
What's under my question is I find it so uniquely interesting, right? When you're talking about the lack of dry ice, right, in town. I mean, that's such a tangible, immediate issue that is very specific to a rural setting. But I think the ways you're describing it sound like I think everybody everywhere is using it in a really similar way. So I am curious to see as it advances, will there be some specific ways that it can be evolved, developed, uniquely deployed where you are so that it does address some of those specific challenges?
It could. I've not seen rural specific applications. I have a friend who's she oversees the Mayo Clinic Google Collaborative, and they're working on incorporating AI into clinical practice in their health system. And so we've had a lot of conversations about what that could look like in rural. We come to the same issues all across healthcare when it comes to applications, at least that we've brainstormed for AI. But I think there's so much potential, and I couldn't have foreseen some of the things that AI is already doing. So, I mean, the creative work, it's astounding to me.
I wanted to back up to just when we were talking about ASCO and, the standing ovation that Revolution Medicine's got. What is your emotional reaction to that? And is there any part of that that is a little different than that you might think for you? Of course, you may be excited about the advancement. That's obviously it's pretty revolutionary, but knowing on the other end just some of the basic challenges that you may have.
Part of it is I feel like I've done this long enough that, when I was in medical school, I saw a patient with CML before Gleevec was approved, and she was pregnant, and she didn't make it because she didn't want to get treatment at a time the oncologist worked with. And now, if she were diagnosed a year later, she would have had a totally different trajectory. I have had patients who, again, in small practice, I know these people, and then, I actually ran with this friend, and in a running group, and he was diagnosed with lung cancer, found to have an EGFR mutation, and he went from basically a hospitalization, massive pulmonary embolism, hospice conversation to he's doing great and he's in remission, and it's been 6 years. And so it's striking. I mean, I look at my certification books and things, and it looks like something out of the dark ages. It's just remarkable how it's changed. And so if there's ever been like a field that's exciting to be a part of, I mean, I feel like maybe cardiology in the 80s and 90s, but oncology now, it's amazing how it's changed, and it's inspiring and sort of, yeah, it is. I mean, you get an emotional reaction to it because it comes down to people and people that and people that have gone through this and benefited from this. And so it's pretty special.
Bringing together like a couple of topics that we've chatted about, Wade, I think, Evan raises the emotional aspect of this, and we were talking about the innovations in oncology care. But I think to point to one particular tumor type in your setting, I'm imagining lung cancer rises to the top.
Yeah.
And lung cancer being a particular challenge throughout the country, but I'm imagining certainly so in the rural setting.
Mm-hmm.
What are things that we could do just to help encourage more screening, help people get screened earlier so that they can benefit from these therapies when they're treated earlier?
Well, I think in rural, there's a lot of issues. There's a stoicism, there's sort of a
Hmm.
fatalism. A lot of people that I know who were ultimately diagnosed with lung cancer did not want to go through screening purposely just because they didn't want to know. In my current practice, which is again more rural and there's more social determinants of health at play, I'm seeing a lot more smoking history. I'm seeing a lot more small cell lung cancer. And so in small cell lung cancer now, as a second line therapy, we have bispecific therapies, which are a lot more labor intensive. We don't currently offer those at Lakewood. We're working on developing a protocol to do that. But I'm not sure if patients understood how much better the treatments are, if that would improve the screening. But I think a lot of it comes down to trust. One of the biggest differences I've noticed between my practice previously and my current practice is, and maybe it's because it's post-COVID, but there's just so much less trust. And
Hmm.
it's very common for me to see a patient who will come in and decline conventional therapy, or they want to try something on their own, or they're going to this other clinic, and then they're, who knows what they're trying, and then they come back. And I take it that they trust me because they're coming back to see me and we're talking and we're open about all this. And like I said, it's really important to meet people where they are. Eventually, a lot of them might consider some of the conventional therapies if what they're doing is not working and we're seeing some progression. So I think that trust building is really important. But I think the trust is a big part of the screening. So again, it's distrust of big pharma, distrust of health systems, insurance companies. So much of that is an obstacle to the screening process. It's an opportunity. And so I think if you have a good relationship with a primary care provider, you're more likely to do the screening.
Hmm.
So I think really encouraging that primary care relationship may be one of the keys. I've seen a lot of work, and there's a couple groups in the state of Minnesota that use a mobile screening unit going around the state. I can see some problems with that too. In some respects, it's really disruptive. I've seen some statistics on follow-up where there wasn't really some good follow-up afterwards with appropriate referral to surgeons and patients declining. A lot of other issues there with the mobile unit. But I'm really a proponent of community-based care as much as we can. And as much as we see consolidation and big corporatization of medicine, even in rural communities, the more you can have the community-based care, the community that really understands the needs of the patient, I think you're more likely to have better screening outcomes.
Brian, I'm going to put you on the spot for just a second. What are some of the ways that you feel like that patient trust gap can be closed? Whether that's a strategy, whether that's education, some other way that we approach it.
A lot of the times we would encourage people to reach out to the advocacy groups, their websites. So many of them have lots of information available, phone numbers to connect with people, communities that you can reach out to. And that's a great place, really for patients to start. It's a trustworthy resource. Somebody could really go there and meet like-minded and other community colleagues here, who are facing the similar kinds of challenges. And I think finding that support and those resources is a great place to start.
Yeah, and I think what's interesting though there is when you compound distance as a unique issue to the rural setting, does it become tougher for patients in those settings to find their support groups? And even if they can find them, can they drive to them? Can they get there to meet with them in person? Wade, do you see that as being something also that is a challenge?
I mean, all these things, even like everything is compounding the other problems. And so distance absolutely makes a big difference there. So, I mean, it makes a case for the mobile unit, but I think as long as it's done right, as long as it's done in cooperation with existing local health systems, you're going to have, I think, much better outcomes. But yeah, I agree with you, and I think there's a lot of opportunity here. Patients know certain advocacy groups really well. Some are very patient focused or patient facing. Others are less so and more for providers and other aspects of the continuum. But I think there's a lot of opportunity there. So I really am hoping we can make some strides in this trust deficit that we've seen develop.
Would you say that there are any potentially dangerous misperceptions that your peers around the country might have about what you do kind of on a day-to-day basis working in a rural setting?
Yeah, I mean, I've had a lot of conversations with, I mean, I just had one at ASCO with somebody who, just the idea that I see everything is just, they feel very uncomfortable with that. Like, how do you do that? Because I have trouble keeping up with this type of lung cancer. It's like, well, I can't have the level of knowledge about that type of lung cancer that you have, but we rely a lot on partnerships, guidelines. You're always learning. It's a lifelong process, but there's that misconception that you can't do that. In some ways, though, you're a general oncologist, and I do think that there's opportunities for fellowships. Lori Rosenstein is a friend and a program director in La Crosse, Wisconsin. She has the oncology program in the smallest city in the country with a program. Anyway, so she understands this, and she helps develop general oncologists. So I think that's a need, and people are recognizing the difference between general oncology and these subspecialist oncologists that develop.
Aside from the general versus specialty conversation, the conversation that you had with your colleague at ASCO, if they came to your clinic on one of these Tuesdays, what else would surprise them?
Hopefully just the level of care. We have a team approach that is, it's one thing to just have a medical oncologist come in and be a consultant, but it's another when you have the patient navigator, the financial navigator. Jeannie Choi is our financial navigator, and she is part of our care team. The patients know her by name. She helps them get grants. She helps them navigate this scary system. It helps them, as they're trying to figure out insurance options. And I have this diagnosis, and I'm looking at these insurance policies for next year. What makes sense for me? She helps them apply for Make-A-Wish and other foundations like that. So she is such a value to us. And there's so many things like that we have that surprise people. I mean, we have a palliative care doctor who just works in our cancer center with us. He helps control symptoms with us. And so I think they might be surprised by the level of care, the level of service.
What you're mentioning there too is the unsung heroes in all of this as well, right? Could you talk a little bit more about that support staff that you rely on, and they're on the front lines with these patients and really trying to help them navigate a particularly complex system?
Yep. And so much of our care too, the patient navigators, so much of our care is not just in our system. I mean, we rely on referrals to the University of Minnesota, to local tertiary centers. I mentioned Mayo. There's so many places like that. Plus, the team, the nurse practitioners I work with. I mean, there was just a paper published yesterday by Robin Zahn about the dyad with the APP and the oncologist. I couldn't do what I do if I didn't have my nurse practitioners there. When I'm not there, today's Friday, I'm Jess Nybakken is there seeing patients for me, with me, and I'll get some texts throughout the day, possibly, but that communication is huge. So cancer care is just not Monday through Friday, 8 to 5. It's around the clock. So it's not only that, but it's the emergency department, it's the hospitalists, it's the nurses in the hospital. So it really is a team approach, I think, more than any other area of medicine.
Do you think that anybody that's practicing in an urban area or an academic center has anything that they can actually learn from the kinds of forced innovations that you've had to put into place? Anything that's a workaround, it's a care model that you've developed? What do they have to learn from you?
I mean, I do think that rural does foster innovation, and so there's been a lot of opportunities like that. We lobbied the state for an appropriation grant. Well, it's not a grant, but an appropriation to develop a fellowship. So it's a fellowship for medical residents, medical oncology fellows, nurse practitioner students, PA students, to spend some time with us. I use Zach as an example. So Zach is now a resident at Wake Forest in North Carolina, and he came and spent a week with me. We met at the National Rural Health Association meeting, and he wanted to see what it was like in a practice. He's a cancer survivor, stage 3 melanoma, diagnosed on his 21st birthday, and he was planning on being a family practice doc in rural Kansas, where he's from. And so he spent a week with me. Eventually, that opened his eyes to the opportunity. He was very passionate about oncology, but rural was more important to him. So now he's on a path to becoming a rural oncologist. So it's really exposure. So I think we see that exposing people to this, making, one of the things that Zach would go back to his practice, to his school, and tell people what he was interested in doing and being a rural oncologist, and he'd just be told, you can't do that. That's not a thing. So I think just getting people exposed to the idea is important. But when it comes to the innovation piece, these innovations, and they're small, sometimes they're care delivery things. We adopt the science that's coming from ASCO and from meetings like that, but the care delivery piece is always changing. And so we do a lot of trial and error, even when it comes to just in our daily practice. And so Jamie is our cancer center director, Jamie Nordic, and we've worked together for quite a few years. I love how she operates. She, something's not working, we'll just try this. She gets some buy-in, and we'll try a new approach for 2 months, reevaluate and see if it's working. And it really does make a good practice environment. So I think it just, we're small, we have the flexibility to do those things. And so there's not a lot of red tape, and it really does make for a good quality practice, knowing that, as I mentioned, the quality of life and protecting our workers and workplace culture are so key to what happens here.
So as we think about wrapping up, I do want to ask you if you could fix one or two things quickly, or if you could even help us identify what those easiest low-hanging fruit things to fix are that you believe could be addressed relatively quickly, what would they be?
Well, I think a couple of things. We've talked about clinical trials, and I do think the decentralized thing is being worked out. Love to see that expanded across health systems, and that would be a really big advancement for rural cancer care. But I also think that the community-based models developed in the community for the community is something that's happening. We see data out of the University of Washington showing that the number of rural oncologists in the country is increasing. And every other specialty that looked at cardiology, neurology, pulmonology, all of those specialties were getting less and less. So I think this is a trend. I think this is happening at a macro level, that we're seeing more and more rural oncologists. But I think that just normalizing this, you can do this in the communities. And so I think that's really going to make a big difference in outcomes. When you look at, I mentioned the state of Minnesota, 75 miles. If we could overcome that. Minnesota is one state. All the states are different. They all have different problems. What works here may not work as well in Tennessee or may not work as well in Georgia. But I think we're seeing practices that work. And I think if we could start adopting those, there's, I think, a hesitancy to change in a lot of systems. But, this is a lifeline for rural hospitals. The revenue from cancer care is a game changer. And I think if you consider currently a lot of that money is bypassing rural hospitals, and no wonder we're seeing these problems with hospital closures.
I think that there are ways we can certainly raise awareness, to some of these issues, and then also really to continue to build the trust factor that you talked about within these communities, because the innovation just keeps on coming in oncology. This is a remarkable time to practice, and you're seeing this with your colleagues. Maybe that information hasn't quite made its way into the communities, and I think it's up to us to really continue to advocate on the patient's behalf that, gosh, there's a lot happening here, and the earlier you can get screened, the better your outcomes.
Absolutely.
Well, Ryan, Wade, thank you both so much. I think it's been a really interesting conversation. And Wade, best of luck to you and all the work that you're doing.
Yeah, I appreciate the time. Thanks for having me.
Yeah, thank you so much.
So what happened to Zach? His treatments worked, and 7 years later, he's a survivor. But they also gave his life a new purpose. Zach became a doctor, and has dedicated his career to improving the lives and care of people with cancer in rural areas. And in fact, Zach works at the Royal Cancer Institute right alongside Wade, our guest today. Now, when Zach sees the highway through rural Kansas, Highway 69 to be exact, he doesn't just see the long road he had to drive. He sees the patients that are getting left behind, and he's working to clear their barriers away. Thank you for joining me on Within Reach, a podcast hosted by me, Evan Young, and produced by Avalier Health with the help of Podcast Labs. For more Within Reach content, including in-depth reports about cutting-edge topics in oncology, patient stories, articles, and more, visit withinreach.avalierhealth.com. You'll also be able to meet our SenseMaker experts who have worked hard to bring Within Reach to life. To get in touch, email us at withinreach@avalierhealth.com or follow us on LinkedIn. And who is Avalier Health? Avalier Health is a global strategic partner for the healthcare industry, working across the breadth of the product lifecycle to ensure every patient is identified, treated, supported, and cared for equally. Our advisory, medical, and marketing teams come together powerfully and intentionally to forge unconventional connections, building a future where healthcare is not a barrier and no patient is left behind. If you'd like to support Within Reach, please leave a review on Apple Podcasts or wherever you get your podcasts. Your input helps us make the podcast even better, points us to topics that are relevant to you, and helps us reach new listeners. All you have to do is open up the podcast app on your phone, look for Within Reach, scroll down until you see it, write a review, and tell us what you think. Join me next time as we continue to uncover issues in oncology and work toward their solutions here on Within Reach from Avalier Health.